It's a pleasure to introduce Dr. Linda Perkowski. She actually came yesterday. We had the good fortune of having her give two of the AAMC Merck workshops, which were outstanding. This past year, she relocated to Central Michigan University College of Medicine. She is a professor there and the Associate Dean for Medical Education. Prior to that, she was actually the Associate Dean for Curriculum and Evaluation at the University of Minnesota. And before that, she was the Director of the Office of Education Programs, University of Texas Health Science Center. She received her bachelor's in psychology from the University of Texas, Austin, her master's in clinical psychology from Texas A&M, and her PhD in epidemiology and community health from the University of Texas in Galveston. She's had many national appointments, including she was one of the founders of Merck and is one of their main facilitators of the workshops. In addition, she's the chair of the Southern GEA, was one of the founding board members of ASPE, the Standardized Patient Educator Association, and president of the Society of Directors in Research in Medical Education. She has written on team-based learning, on education fellowships, standardized patient research, and remediation strategies. Today she's going to talk to us about the challenges of self-assessment and feedback. Thank you. Thank you.
And thank you all for joining me here. I appreciate it. And thank you for giving me this opportunity. Actually, when I was asked to speak about something, I was looking at the literature on self-assessment and feedback because I thought after 5 medical schools and 30 years in the business, I wanted to figure out how to get it right. And I'm not sure that I'm going to be able to, but I wanted to at least engage you in a dialogue about where we are with this concept. It may be a bit presumptuous of me to use a Midwestern analogy here. How many of you know what Lake Woebegone is? Okay, well, since I'm from Minnesota, this is a fictitious town in Minnesota hailed by Garrison Keillor of Prairie Home Companion. And the reason I bring it up is, can you hear me? Because this thing's heavy. This is Garrison's introduction to Lake Woebegone. All the women are strong, the men are good looking, and the children are above average. And this relates very well to my topic about self-assessment. And in fact, in the literature, there is the Lake Woebegone effect, in which we tend to think a lot higher of ourselves than perhaps we should. So I want to refer to Lake Woebegone, and I'm hoping that will help you remember a lot of the concepts. Why is this important to this profession? Well, as any profession, this thing's not working for me, sorry. Are you getting? Okay. We need to be self-regulating. And self-assessment is key for that self-regulation. A recent article in JAMA said self-regulation is central to medical professionalism. But the literature tells us, and this is not just the literature in medicine, this is the literature in most professions and non-professional groups, self-appraisal is very inadequate. It does not help us as a mechanism for performance improvement. And one reason I wanted to talk about feedback in relation to self-assessment is that if we can't self-assess very well, we're going to have to rely on external information. And so what are the processes through which we can become better at what we do? So the goals today are to give you a very brief review of what's going on in the self-assessment literature. Actually, that's a hot topic right now in medical education. And I've given you some selected references that may help you if this is an area that you're interested in and want to know more about. I want to talk a little bit about some of the processes for effective feedback, but I really would like us to focus on discussing, so what can we do to our environment to help with this issue? I'm going to quote a lot from who I call the master of self-assessment, which is Kevin Eva. He's now in Vancouver. No matter where you look in the literature, and there are hundreds of articles in the literature, and multiple methodologies and systematic literature reviews, and the consistent finding is that self-ratings are poor, especially when we contrast them to external measures. Yet, I would guarantee there's somewhere in any of the programs that you're in, whether in GME or UME or CME, where self-assessment has been a requirement for you to develop or look at or assess in your learner. I'd like to start with some of the definitions. When you think of self-assessment, do you think of it as this first definition as an ability, something somebody can do? That's one of the ways in which it's articulated in the literature. It's an ability. It's a personal, unguided review of our performance. But in fact, probably what we should be focusing on is more the second, the informed self-assessment, where we're seeking assessments about ourselves from others. It's a pedagogical strategy. And that's encouraging to me because if it is a strategy, it is something that we can probably help our learners to develop. But what we're really aiming for is reflection. The expertise literature tells us that that's the goal of an expert, is to be a reflective practitioner, someone who actually puts mental energy into efforts to improve what they are doing. So just knowing that you're doing something poorly doesn't help you. Why are we poor at this? Well, this has been a problem for a long time. Ben Franklin recognized it as a problem. We, in general, don't do any kind of self-assessment well. This may not be a good analogy. I was just talking to a gentleman about New York. How many of you drive or have driven in the past? Okay, I know you were saying you mostly walk, but think about driving is usually something everybody does. And I was in Texas a long time. Everybody drives in Texas. So think about driving. Just think for a minute about driving. How many of you, when you had that image in your head, broke it down to, got in the car, turned the keys, looked at the gas gauges, checked the mirrors? Was that the image that you had in your head? Okay, what were you thinking? Driving. You were on a road somewhere, you were in the city, you were driving. This is the way we conceptualize a lot of our activities. So if there was something wrong, would that gross thinking help you to change your behaviors? Probably not. You'd need to break it down into those individual actions so you could say, I'm a great driver, but I don't check my mirrors. I'm a great driver, but I'm a little heavy on the gas pedal. But our first reflection is usually at the global level, not at the specific level. That's one of our problems with self-assessments.
Interesting you mentioned driving, because that's probably a sphere of human activity where everybody believes that they're a good driver.
It's not, unfortunately. I mean, yes, but the literature tells us it is not the only activity that we think we're better. It's very, but it's a good one for, usually, it's for leveling it, because most people think they're pretty good drivers. And what's the second part of that?
But there's objective criteria for that.
There are objective criteria, and it's behavioral. Mm-hmm.
You know, you can tell. I mean, a kid's a good driver now, but how many accidents are reflected in my insurance? It's the people you want to choke the hell out of on the George Washington parade.
That's it. What's the corollary to that? You're a great driver, but the person next to you is not, right? You're better than any of those other drivers. I mean, that's usually the way we look at this. Even though there's objective criteria, we see ourselves as here, we see others as here. Now, if we had data describing your two colleagues, you might say, no, they're probably as good as me. But driving down the street, most of us seem to think that we're good and the others aren't. So it's in our hardwiring. There are multiple reasons why this is the case. One is cognitive. You may not know what the good criteria are for good driving. You know, that's why we do driver's training. We may not know what constitutes it, so we can't really self-reflect well. But in addition, we're not always as effective as we'd like to be with our memory. You don't access your memories directly. You access them through other cognitive structures. And so there's probably some biases going there. I asked you to remember driving. You remembered an instant driving. You didn't remember every single instant driving. You probably didn't remember today's activities. You might have remembered some more global activities. There's the sociobiological. There is the Lake Woebegone. We are optimists by nature. There's a higher likelihood that we're going to seek desirable outcomes, that we're going to see that there are going to be desirable outcomes. So Lake Woebegone is not just a Minnesota phenomenon. This is a human nature strategy, and it's probably adaptive. You know, if we thought that nothing was going to work, we would probably not get out of bed in the morning. Oops, sorry, didn't want to go there. How do I go back? Keyboard. Thank you. Nope, that's not working. Go back. Sorry. The final one, also, when you were thinking about driving to this optimism thing, how many of you thought about an accident that you had or difficulty that you had driving? Did anybody? You did?
I always think about that when I drive. That's what forms my pathways of what I do.
Okay. Most people think about something that they did well. Your personal experience can often influence how you analyze the situation, but many people will think about driving very well down the road, not thinking about what the problems are, not thinking about what the challenges are. And finally, we tend not to. How many of you feel like you get good feedback from your colleagues? Anywhere. You're an anomaly. I love that. It's one of the most prevalent comments that I have seen in all the schools that I've been and in some of our accreditation visits from students is, I don't get any feedback. I don't get enough feedback. I'm not getting good feedback. It's a pretty ubiquitous finding from our learners that we're not getting enough. And there's reasons for that as well, and I'll go into that. There was an interesting study to show how ubiquitous this construct is. There was an interesting study in 2008. It's a qualitative study where they did focus groups with over 134 individuals in 5 countries in 8 different training programs. So this wasn't just at the undergraduate level. It was undergraduate all through practicing physicians. And they asked them about their perceptions on self-assessment, specifically in the clinical arena. And they found 3 major thematic responses. There were tensions in this whole self-assessment construct for self, between people, and in the learning environment. So self, this is probably intuitive. Why is it hard for people to seek feedback about themselves? You want the feedback, but you don't want them to tell you something that you don't want to believe about yourself. So if you don't ask for feedback, you don't have to worry about getting any disconfirming information. But the other is, going back to our self-assessment, if someone gives you feedback that is incongruous to what you believe about yourself, you don't perceive it as valid feedback. And there's the rub. If we're not good self-assessors, if somebody gives us feedback but it doesn't meet our self-assessment, we're not going to accept it. There is also tensions between people. And this happens a lot, I think, in our hierarchical academic training settings. We want feedback, but we're concerned. You know, think about your PGY1s, think about your medical students. They may not seek feedback because they're concerned that they're going to be perceived as incompetent. Seeking feedback from others is not always considered a positive action. They may not trust the feedback that they're giving, either because it doesn't fit with their perception or because they don't have a valid relationship with the individual who's giving it to them. This comes up again all the time. I hear this from students. Well, he only saw me once. How in the world could he give me any input on my behavior in the clinic? And finally, is it a safe environment? Do they feel safe being able to get feedback? And finally, we have to go at the global level to the learning environment. Are you familiar with the term hidden curriculum? You know, it's the real stuff that's going on. It's not the stuff that's in the book. It's not the stuff that's in the syllabus. But it's how each place looks at the learning environment. And as I said, having been at now 5 different places, it's the culture that matters. And each place is very different. I wouldn't say the curriculum has been that different, but each place has been very different. And finally, and this is coming to light now, do your students or residents fill out any kind of a portfolio as a self-reflective exercise for assessment? Or do narrative kinds of evaluations? They're becoming more popular as a tool for self-reflection. But there's challenges in the literature and in reality about, are those really helping our learners to self-assess, or are they, again, playing the game? Are they putting in their reflections that they figure you, as their evaluators, want to see? So from this study, as I said, that was pretty comprehensive and across multiple cultures, there was a consistent message that this is difficult at the individual level, at the dyad or triad level, and at the institutional level. Questions about that? So how does this apply to health? How many of you are physicians in the room or healthcare practitioners? Many of you. So you know this or you experience it with your patients. Most individuals, and the literature again bears this out, are pretty optimistic about their health risks. They know that smoking is bad for you. They know that drunk driving is bad for you. They know that obesity is bad for you. But that's bad for you. It's not necessarily bad for me. My risks are not the same as my peers. Yeah, I may be at risk, but I'm not as at risk as my peers. This is impacted by what has happened to you in your life. If you've had an experience with a bad consequence for your health, you may not have that same high optimism about your health. What's the problem with that? I mean, it's good to be positive. The problem is no motivation to change your behavior. So again, another ubiquitous finding. One of the other findings that comes out in the health literature is that when we delegate our health decisions to someone, their perception of what we want and how we need to be treated is not the same as what our perceptions are. So they may make choices for us that are not in line with our beliefs. And finally, we diagnose ourselves based on either the symmetry, those of us who are not physicians, diagnose ourselves based on the symmetry rule or the prevalence rule. If we have symptoms, therefore we have an illness. And if our symptoms are rare or unusual, it's a serious illness. You know, as clinical faculty, that doesn't bear out in reality, but that's the perception that patients are coming to us with. So what's the solution? Again, back to Eva and Regehr. I'll just let you read it. We just need to get everybody to self-assess better. Simple. Except that it isn't. The reality is that we shouldn't even be thinking about self-assessment as that habit, or as that ability. It isn't an isolated or an individualistic activity. It has to be done involving others, peers, teachers, and other sources of information. That may seem counterintuitive, and I think it particularly does to some of our more assertive learners. I can learn. I can learn myself. I can improve myself. In fact, no, you need the help of others. You need the guidance of others. I don't know how many of you have ever seen Johari's window. This is from a social psychologist, Joseph Luft and Harry Ingham. They developed this to help some of their patients to understand why they weren't seeing things the way others were seeing them. They actually did a card sorting type of process. So they gave you cards to sort about yourself and gave your peers that knew you cards to sort about you, to point out to you that you have problems in that upper right-hand quadrant and the lower left-hand quadrant. We all have blind spots. We all have knowledge and information and thinking about ourselves that is not what others have. So we need feedback. What is feedback? It's a corrective corrective mechanism for the individual who wants or needs to learn how to modify their behavior. It drives performance. It's a key to adult learning. And remember, I was saying reflection is really a cornerstone for expertise. Feedback is a cornerstone for reflective practice. So I'd like you just for a moment to turn to somebody close to you and talk about a time in which you got feedback that actually changed your behavior. Not that you thought was good or bad, but it actually resulted in a change of your behavior. I don't care how it was delivered, how did it work for you? I want to get some themes about what worked and what didn't. Pick somebody to talk to. Just pick one. Just pick one. We don't have all day. Just pick one. Or to talk to your colleague. I want to get some consensus here about themes. Okay.
I was actually thinking, I mean, a lot of it relates to my family, where I feel I get feedback. It's probably not intentional, but they'll say, "You're so crabby today," or my significant other will say, "You know, that made me feel so bad," or, "You know, why did you have to say that to me?" And I didn't think I said anything wrong, and I may not have, but I didn't appreciate that he was particularly sensitive about it, and so I've actually changed the way in which I say things to him because it bothers him, or the things I say are not going to, you know, change anything in his behavior. So he has road rage, and it makes me crazy. And he will call me when he's driving and screaming, and I used to say, "Tim, are you in a rush? Do you have to go anywhere?" "Don't tell me that." So I just let him vent, and all he wants to do is really vent. But I want to fix things. I want to make someone feel better, and so I understood that is my nature, and that often people just want to bitch and they want you to try to fix it. And so I have learned to try not to fix everything. You know?
So it's been consistent feedback over time?
Yeah.
Not just an episode, not just an event.
You mean with him?
Oh, yeah.
Well, in general, I tend to try to fix everything with everyone. And, you know, when I've talked to therapists, they clearly say that's the Mother Teresa thing, and everybody jokes and calls me that. But I don't realize even at a little level, like, you know, just trying to make him feel better because he's in a rage state because he's stuck in traffic. You know, or he can't find a parking
And he's a good
spot.
driver.
Yeah, well, I don't know about that, but he thinks he's an incredible driver, and they're all morons, as you said. But my children will say the same thing. You know, that made me feel really, really bad, and I didn't mean to say that, or just, you know, it reinforced something.
So it's from somebody that you thought, I'm trying to look for themes,
that I care
that
about.
you really care about, that you thought is credible,
That's
that
right.
knows you.
Right.
And
I think I've probably heard it enough that I can't ignore it. You can't
So
deny
consistency.
when they first say, "Oh, you're coming home crabby," but then when it's like, and then it forces me to reflect upon myself and why did, you know, and I might say to them, "Why are you saying that?" Or I might stop and think, "Well, what about my behavior made it be that way?" And also in my interactions with my son, which are very difficult, I will often have an angry tone because I'm very angry at him when I don't mean it and when it's irrelevant, and he hears it, and my boyfriend will tell me and say, you know, even when you're not trying to, there's that edge to your voice. So, you know.
Yeah, so it's the people. It's
right.
the people.
That's
okay.
right.
I don't want to take up. Did you have time to share? I don't want to know the incident so much unless you feel like it's necessary to tell me that in order to get at it. What I'm looking for is characteristics of that feedback that worked for you. Yes.
going about it, but 27 years ago, I started at Elmhurst Hospital, running the inpatient pediatric unit, and it was busy service, and the guy who was just about to step down after 33 years as the head of pediatrics, Mel Gertner, called me in his office, and he said, "Scott, I have 4 words I would like you to consider. Gray is a color." He said, "You can go now." That's all he said. And I tend to be black and white, but understanding that there might be this sort of King Solomon middle ground, that not everything is so cut and dry, it was the best piece of advice I ever got at work. He didn't have to spell it out. I knew exactly what he was talking about. Short, sweet, to the point. Goodbye now.
So it changed your behavior by making you reflect on things a little bit differently?
Right. I realized I was beating my head against the wall of other people by not trying to see a middle ground or a middle solution. And, I mean, I have a fairly political job at this point, and I clearly don't think I would have gotten the job or been able to be even remotely successful if I hadn't learned that 4-word lesson.
And we were just talking too, you trusted the person who was giving this to you. You valued this person, thought they were credible. I think that's one of the key things. Somebody else, me saying this to you, you probably could have cared less. But having this person that you care about.
Besides the fact that he controlled my paycheck.
But that's not what I heard. When you introduced it, you talked about being a person with experience and wisdom, particularly in the context and the culture in which you were in.
Was and is a great role model.
Yeah. That's important for feedback. Very important. Yeah.
I have a question about your definition of feedback, because it sounds like your definition of feedback is more negative feedback than positive feedback, because you're talking about it being corrective, as opposed to positively giving feedback when a learner
Good
does
point.
well and reinforcing that behavior as opposed to asking them to modify it.
Yeah, I didn't get into this for this presentation, but really, feedback is an engineering term. Feedback is really about correction. It is about correction in missiles and things. What we really want to do, perhaps in our profession, is more reinforcement of positive behaviors. So that is not an incorrect definition of feedback. We use feedback in a much more ubiquitous way to cover a variety of things, corrective as well as reinforcing. But you're right, that is probably for, it went off course, how do we get it back on course?
Can I ask a question?
Yep.
Because there's something that I'm not exactly clear about. Through your talk, you've said implied that people often see themselves in a pretty good light, and they're surprised when somebody says something bad. I don't know much about that type of world, but from some of the readings I've done, and my wife's a shrink, talking to stuff I've heard stuff, I've gotten the idea that a lot of people don't feel that good about themselves. Indeed, from my own interactions with a number of my students, I'm pretty surprised how unsure they often are, and that it's not that they feel too much about themselves or they're right about themselves, but they feel uncertain and sometimes too insecure. It's like that funny thing that used to be on Saturday Night Live with that fella who would look in the mirror and said, "I'm good, I'm handsome, I like myself." I think he went on to be a senator or something. But I wonder where it came from that most people inherently feel that they're right and they're strong and they're good. I'm not sure, I don't know if the data says that, I guess it's so, but just doesn't seem that way with a lot of people.
It's about our perception of abilities, and I don't disagree, and I certainly wouldn't disagree with your wife, who has far more training in the area of mental health than I do. And I do think a lot of our learners are very insecure. I haven't even talked about the impact of the affectual responses to a lot of this feedback, and a lot of the reasons we don't feel good about ourselves is because the feedback we got is discongruous or it was done in a threatening way. So I don't mean to everybody's out there on Prozac being happy. It's just our judgment of our ability tends to be higher than what it is. And in some of and this has been more in the psychological studies than in medicine. So medicine may have some, it's one of the things, one of my conclusions is we need to do more research with this population, because I'm not too sure some of these general statements are as accurate in some of our learners as they are in the general population. But there's been work done, since the 50s on people's perception of their ability to do tasks, just tasks. And generally, the poor performers tend to think they're better. The good performers tend to think they're worse. So to your point, our high-achieving medical students are probably underestimating their ability. I think they are probably underlying still optimistic, or they wouldn't even come to medical school, for example. But they tend to underestimate, whereas the poor performers, haven't you had the resident who's really struggling, or the medical student who's also really struggling, deny that there's anything wrong, or blame the system as opposed to their own performance for what's happening? And I think that's sort of this is black and white, and it isn't black and white. It obviously is a little gray, and the emotions do play into it, yeah. I'm sorry.
Yeah, I think that if we think about medical students, it is very different, and there's some literature that shows that they come in with higher perceptions of their skills, and as they go through medical school, when they recognize what those skills are, their perception of themselves actually decreases in terms of ability. But they're getting constant feedback, and they're in a huge group. So they're always getting your score was a 70 and the mean was 80. So, or your score is 90 and the mean was 80. And so when you're in an environment when you are in close contact with a lot of people and you are getting comparative data, which is what happens in the first 2 years of medical school, I think it is harder to ignore that data. And so I think our students are probably far more perceptive. Plus, what always happens is that they're in the top 5% in college and someone's in the bottom 50% in medical school. And so I think that reality is tough for them, especially in the beginning. And so I think they may be a little bit more self-aware in the beginning, and then not through residency and beyond. But I think we select for, not Mount Sinai, but medicine selects in part for individuals who have a slightly better ability to self-assess themselves, at least in the beginning.
Okay. I don't know. I don't think from what I've looked at the literature and from my personal experience that we do a very good job of selecting people who self-assess. I think they're very good at self-assessing certain things about their behavior. But like one of my worlds was standardized patient. The student, we have it on tape. The student would come out of an encounter saying they did X, Y, and Z. They didn't do X, Y, and Z. They just didn't do it. And yet they would argue forever that they had. That's the way they remembered it. That's the way they perceived themselves. It wasn't trying to be duplicitous. I mean, they weren't lying, but they really didn't see what they were doing that was inappropriate. And so, I don't know. The reason I'm bringing this forward, actually, is it's a concern of mine that we may not be sensitive enough to this, both from the emotional and the affective point of view, as well as from the neurobiological point of view, that we're really helping our students. They're developing, helping their metacognitive skills, helping their ability to think through what it is that they're doing and plan an action that actually improves their behavior. And we don't do, and I'm not going to get into that today, but we don't do a good job of our assessments. So I think we might be missing some of this because we are assessing at this level and the issues may be at this level. But because there's this incongruence between what we want to hear and what we're hearing, I think that does affect them. I think that does make them feel not good about themselves. One of the recommendations in the literature was, and I thought, okay, great, that's a nice recommendation. How do we do it? Give feedback that doesn't impact their self-concept, that only improves their self-concept. Well, that's a fairly, your wife could speak to that, that's a fairly sophisticated and challenging skill. And in a busy academic medicine environment, That's really hard to set up a trusting, caring place. I didn't get to hear the rest of you about feedback, but both of these instances, it was somebody that you cared about, somebody that you valued. That doesn't happen a lot of time in our busy academics. They don't always have that kind of relationship with the person who's giving them feedback. A couple other examples about feedback, something that worked for you? Anybody else have something? Besides it being from a trusted advisor, what worked?
Someone from an athletic coaching standpoint, I'm sorry, from an athletic coaching standpoint, which is the same thing. It was pointed out to me that when I thought I was asking the question, I was really leading the answer. So I would say at the end of the session say, so we're all got that, right? Everyone on that? Let's move on. And they said, you weren't asking them to say yes or no. So what I had to do is stop, and it's hard to say, did we get that? Or who did not get that? Or who did get that? As opposed to, we got that, right? Everyone on board? Everyone up to this? Everyone understand the play? And so the leading question, so it changed the style. And
so it was pretty specific.
it was specific.
It was something that you could do. You could change the behavior. We weren't asking you to do something you couldn't do.
Right.
And
it really didn't matter who said it, actually. It was just once you...
But it was timely and specific.
You said, that's right.
And you were ready metacognitively to hear it, too. You know, okay. Anything else? Anybody else had something that they wanted to? Yeah.
We talked a little bit about the timing of feedback,
Mm.
and that, or I was saying how it was more helpful not at the peak of a conflict or a stressful situation, but a little bit afterward to reflect on something and actually be able to absorb feedback.
Yeah, timing is important. And again, there's the literature and then there's the real life. And I think that's also a challenge that we have in our environment about how are we going to time feedback so that somebody can hear it. You can remember that you probably heard in your head that you were giving a leading question. If somebody told you that 3 months after you said it, you might not even remember that you said it. So I think timeliness and the affectual part of it, not in the crisis of the moment. There's obviously been a lot of literature. And what I liked about this particular article, even though it's back in the 90s, is they looked at multiple models, because there's lots of models out there. But they all have elements like this in it. Was the person prepared, or did you prepare somebody for it? Did you ask the person what they thought for their self-assessment? And what would be the reason for that if, in fact, you can't self-assess? Why would you want to know what they think? That seemed counterintuitive to me at first. I think it's so that you can take them from where they are to where you want them to be. You know, if they walk out and said, got that, I aced that. I think that the way in which the feedback would progress would be different than if they came out and said, this and this and this are what I did wrong. There needs to be a discussion about what needs to be improved. There needs to be explicit strategies. You got explicit strategies for how to change what you were saying. You need to apply it to real-life situations. And then both of the people who are engaged in a feedback encounter need to walk away with an understanding of what the next steps are. But context matters. Just because you have the ability to absorb feedback about your leading questions does not mean that you're going to be willing to accept feedback about another aspect of your life or your behavior. So, and the situation matters. If you're in a crisis situation, there can be explicit feedback that needs to be given right then to the learner. And you can't have all this lovely setting up the context, setting up the, it has to be done right then. So context matters a lot. And perceptions matter. There was a recent study in medical education, actually this past month, again, a qualitative study looking at what people thought. And many of the trainees, this was in-depth interviews with 22 trainees. I think they were at the PGY1 level. And they did not view the feedback they were getting as credible, trustworthy, or oriented to their learning. And the reasons for that was because of the relationships that they had with these individuals. They did not feel that they had a sustained, meaningful relationship with the individual, and therefore they were discounting the feedback.
Is it also possible that they knew that the person who was giving them feedback was a jerk, and they didn't care what they said about them?
I imagine that's true, too. You know, knowledge is both positive and negative. You know, the person that you felt gave you good feedback you valued. If it's somebody, but why did they think they were a jerk? What was the reason? Maybe they really were a jerk, or maybe they didn't know enough about the...
We got plenty of jerks.
I'm sure you do, I'm sure. But maybe they didn't know enough about the individual to make a good judgment about it either, you know, or it wasn't delivered in a way. But what this pointed out, at least from this study, is that there's a lot of energy in this system going on about people doing activities, people getting feedback on the activities, and nobody's improving because of it. You had a comment or a question?
On feedback expectations, like I'm reading this, and Scott said maybe the person was a jerk. Some of us are limited in what we do. We're not psychologists. We are living within the bodies we have. We have voices we have. You know, I was thinking when you asked for an example, and who helped me, I was having a problem with a student. I went back, I spoke to my wife, the psychiatrist, and she said, well, you know, it's not what you say, it's how you say it.
Mm-hmm.
It's the tone of your voice. You're a large, scary male. I can't change some of those, I can't change others. But in a box of feedback expectations, it seems that sometimes maybe you're expecting, or the world is expecting too much
I think
on the
so.
part of the feedback giver.
I agree.
And I know that in our school, which is a wonderful school, with our students expect a lot, and a lot of communication, a lot of interaction, that we may disappoint them.
Mm-hmm.
You know, maybe the person wasn't a jerk, Scott. I mean, maybe they were just a tough, cold, whatever they're doing, and wasn't fuzzy-comfy in that way. So I'm just wondering, there's another part of I want to be the best
There
I
is
can
good.
possibly be, but I'm not going to morph into Mother Teresa. You know, it's not going to happen.
Yep.
I could try. I sit there and I talk in front of a mirror now before I give table conferences, so my tone is not bad. I have a checklist not to roll eyes, don't look away, don't say. Erica taught me all these things, and I practiced that. But invariably, something happens.
Yeah. I mean, we're not. And the fact that you're trying to do something different is phenomenal, but we're not perfect, and that's why a model is not going to work. I mean, it doesn't work for everybody, it doesn't work for every situation. And one of the things, probably won't even get to it, one of the things that I have felt that we are not doing, I don't know if you do it here, but in every other place I've been, we spend a lot of time working on your behavior and your behavior and your behavior as faculty. And we've done nothing on the receiver side. We've done nothing for our students about how to receive feedback, about desensitization to the fact that sometimes you're going to have big, scary people giving you feedback. And how do you, as the receiver of the feedback, work to accept that and learn from it? It's not, remember the tensions were individual with other people and with the environment. We can't just fix this by more faculty development. It's not going to solve the problem. Yeah. Go ahead. Oh, sorry.
These were medical PGY1s.
I think I may be misremembering. I think.
They're much more receptive to the feedback if they were PGY4s or 5s.
Yes.
Because I think it depends, that's part of the context in which you give the feedback.
Correct.
And sometimes you just need more experience in order to understand what's being said to you.
Yes.
I mean, I learned an awful lot as an attending from other attendings.
The literature on expertise and experts say that they're the people who take and receive more feedback than anybody. because they, just like you, they know more, they have more knowledge, and they also know that they don't know as much. And they're willing to learn from it more than the younger learner who's probably defensive and probably fearful that they're going to look bad. You had a comment?
What do you think we should do about teaching students or house staff to actually give feedback? Because as a course director, I read the evaluations the students give us. You know, some of the feedback is very, very useful, but I'm sure other course directors can also agree that some is sort of, you know, very frightening. And we talk a lot about giving them feedback, you know, faculty working on how we deliver it. But do you think we should try to?
Well, I don't think any of the faculty development that you've been talking about is bad. I mean, it does change behaviors. It does, you know, and there's pretty standard things, you know, the timing, the tone, the specificity, the contract. Talking about helping the learner to get to a goal as opposed to the comparison to others. You know, there are things that we can continue to do that help our faculty and help us as individuals. But I think it's, if I could change one, had a magic wand and could change one thing in medical education, it would be to make everybody good feedback givers, because I think it's really hard. And I think we have an environment that makes it challenging because it's hierarchical and because it's very rushed, and it's getting more rushed. And it's hard for anybody to hear something that's delivered quickly and in a unsafe environment, i.e. somebody's grading me on this, or patient safety. You know, there's a lot of variables here that make it very, very difficult for our learners. And I have a slide that I thought was just cute. I want to talk about generations, too. Sorry. Sorry, I don't know this one. I'm not doing this well. Apologize. I want to talk about generations. You know, you almost feel like you need to hold up a sign saying, I'm giving you feedback right now. But some of these are things that work, that we really need to be thinking about feedback that's for your learning, for where you need to go, not of, you did this wrong. What we really want to do is, what are our goals, and give the feedback of how well you're getting towards those goals. So formative rather than summative. Because what we really want is to help them become better reflectors. And I think it's hard. I think this is really hard. I don't have all the answers. One of the things, somebody mentioned this, the literature is telling us we really should focus on critical incidents. When students are trying to become independent, they really want to become independent of. Residents are trying to become independent. They want to be sole practitioners. So we want to give them feedback when they're at the edge of their competence. We want to give them feedback when they're moving to something where they're going to become independent. So it's areas where they're unfamiliar or challenged or uncertain. They don't really need the feedback on the common things. And I think we spend a lot of times on those because they're easier to give feedback on. I don't think that answers your question. I wish I had an answer for your question. I have more questions about this than I have answers. But I think that some of the tried and true faculty development programs are good, but we don't spend any time on the learners. We don't help them to be the receivers of the feedback.
We want to help them give feedback, too.
Help the learners to give feedback? Yes, yes.
They do. In ASM, they do. So they have to comment on each other's oral presentations in group. So there are a number of instances, even in the teens in anatomy, the students are supposed to, you know, give feedback to each other about whether or not they're participating, learning what they got right or wrong. So, I mean, there are a number of instances where we try to do that, but it happens quite a bit in ASM too, actually. And the students are in pairs, and then they have to talk to each other about what parts of the physical exam they got right or wrong. You know, whether that's enough or not, I don't know.
Practice with them how to give feedback on courses.
Well, it's never enough. I mean, all of you are saying, I wanted to be able to give feedback better, and you've been at this for a while. You know, we're not going to have them all be perfect by the time they get out of undergraduate. Yeah.
A lot of what I'm thinking about is sort of summarized in this slide here, but I'm a palliative medicine faculty member, and we have a course that we've developed, communication course for palliative medicine and geriatrics fellows. And I've done a lot of faculty development with Bob Arnold and Tony Bach, who are the OncoTalk investigators.
I've heard of them.
And what they train us to do in terms of feedback is to try to teach our learners to be reflective in their practice.
Right.
So we're trying to get the learners to be able to give themselves feedback, essentially.
That's
It's a great idea, but the challenge I find in a particular example is that we were giving feedback in this method to one of our fellows, and we had gone through a whole brainstorm. We told her we were going to give you feedback now. A whole brainstorm session of, what went well, where did you feel stuck, what are other things that you could have said in that instance to get yourself out of that stuck place, with that stuck place being that learning edge, and the place where she's ready to learn and where she needs to learn. And we finished. We had done this whole brainstorming session with 2 attending from the fellow, and we finished, and she said, so when am I going to get feedback on this? And we're like, well, that's what this just was. And she said, no, but when are you going to tell me what I did wrong? And she is so attuned to that's what feedback is,
right.
being told what she did wrong, that I don't know how well we did with her in trying to help her develop that self-reflective practice.
Yeah, because the expectations were different.
And that's how we always are telling people how to give feedback is the corrective, and how do you modify, and this is what you did wrong, and this is how you do better next time. And so how do we get to that higher level metacognition of people thinking in this way if all we're doing all along is saying this is what you did wrong and this is what you can do better next time?
Well, I guess that's what started my thinking on this. I'm at a new school, in theory. We have a new opportunity to set up a culture, in theory. How do we do this so that that becomes more the norm than the corrective part? Because it's really hard to go back and, I don't have an answer for that, because it's hard to go back and not do it. I mean, you do it enough times, I'm sure eventually the penny will drop and the person will see that. But you are fighting a lot of conditioning to another model. Yeah.
I think you said you were going to mention something, and I wanted to touch base on it before our time runs out and whatnot, about generational.
Yeah, I had a couple of slides, because that's another confounder.
The question I have is, we were assuming that in some ways chickens can give advice to ducks. And that is built into our systems. I know I've been thinking about that an awful lot, because will somebody who has totally different wiring in ears hear something that I say, no matter how much I practice or do?
Yeah.
My son says to me all the time, I'm not going to come visit you, he's an MD, PhD, if you keep on yelling at me. I don't raise my voice to him.
But you're big and
I
scary
know
and
that
intimidating.
in his generation, asking him to do something he doesn't like means yelling. My daughter says the same thing. So perhaps some of the equation is wrong. Maybe
Yeah.
for example, shouldn't give that feedback. Maybe, and we've been thinking a lot, that we should have it come from a teaching assistant or somebody who is closer to the student, because it's not going to be a wall. Oh my God, if I say something wrong, Dr. Layton can fail me, or this can be there. If that's in the mindset, it will take a long time to gain that trust. That's the key thing in feedback. And whether or not we can actually achieve that trust, no matter how friendly we are, nice we are, modulating our tones we are, it's a different kettle of fish. I'm talking mostly about the early years.
Yeah.
Often when you would say something to a resident, they were on pins and needles. There you are. That was a good surgery, did a good job. That could lift them to a new level.
But that's what you just said is a corollary to what I said.
Yeah.
Because those students will take the feedback from a first-year resident, whereas they think when they're getting it from the attending that it's all wrong.
Right.
Yeah.
Because of the narrower the gap, the more likely you are to be able to accept it. Because it's coming from somebody who is not so far ahead that they're of a different generation.
Yeah, and so again, I think there are more questions here, and is that the way we have to now start articulating our processes? Because this is a gross generalization. These are cultural generalities. This is not how everybody in that generation works. But the point is, we have not made explicit contracts between the different generations on how we want feedback or how we're going to give feedback. but we have different expectations. We grew up with different expectations, and we have different ways in which we want to communicate. You know, and it's only going to get more so in terms of what people want. And what do we do? How do we think about how we're designing our training protocols and our training so that we are at least trying to meet those needs? The fact that you're so sensitive to this is phenomenal, but it's a big issue, and you're both working against a strong culture that doesn't necessarily support that. And yet, this is why I keep going back to what I'm seeing in the literature. We don't do a good job of knowing what we don't know. And if we don't, then we've got to rely on others. We've got to rely on the people who know and can observe and can give us feedback. So it's not something that we can not address, I guess, is my concern. It's not something, even though it's hard, I think we have to keep struggling and figuring out a way to do this. Or we have to really improve our assessment methods, which is a whole different topic, because I'm concerned that we're not necessarily seeing how we can improve our learners. And is that chasm going to get bigger because of generational differences or other aspects? I don't know.
I was going to say also, it's problematic if we don't teach our students, because as residents, they're giving feedback to the interns. As attendings, they're giving it to the residents. And if they haven't seen good feedback, if they don't learn how to do it, it's self-perpetuating.
Yes.
So, you know, endless. But I think, you know, as you said, the really important thing is the context of it.
Mm-hmm.
You know, if you're getting it from someone who is grading you versus you're getting it from somebody who has no impact on your ultimate grade, it makes a huge difference, I think, for most people.
It has to be a safe environment.
Right.
Yes. And yet, then do we get into the issue of, but do they really know what I should be doing or what I need? I mean, it's challenging. And I know, having just gone through 3 accreditation visits, that issue of conflict of interest and people in a position of authority and giving feedback is a very touchy one, you know, and I think we do need to be aware of that.
But
And seeing time here, we've gone
that's
over.
part of the benefit in theory of having a mentor.
Yes.
Because that person is not grading you, and they should be honest in terms of giving you feedback and forcing you to look at yourself and where you are, and, you know, I mean, that would be the ideal.
Since I'm obviously out of time, this was my thought. I mean, we need to definitely continue faculty development on this, but I think we need to be more explicit about some learner development initiatives, as you're doing, and we could do more, I think. We're learning that whole emotion is huge. And I just read an article that was published last month saying that there is hardly any literature at all about the affectual component of our medical education training. And clearly it's there, but we're not studying it. We're not looking at its impact. We're making assessments based on our anecdotal data, but we're not doing any systematic work in this area. Desensitization, your wife and others could help us to learn how to desensitize. They're going to get negative feedback. They should be getting negative feedback, but they need to hear it. And I think we want to be able to train them, as you're talking about, to actually work through this at a metacognitive level. I think that's, yeah, all we had. I wanted to go back to Lake Woebegone. You can't fight human nature, but we need to be aware that that's going on, that we may have challenges with our self-assessment, that we do need to do a better job with our feedback. And we need to think about changes, not just, it's wonderful for us to become better at feedback, but it's not just about our skills. It's about our learners' skills, and it's about the environment that we set up, the learning environment. And to me, that's an important message. Again, try and start something new. It's an important message of what environment do we want to set up so this will work. Apologize for going over, because that's...
Two other thoughts. First is, I don't know if anyone read Tolga Wande's piece in the New Yorker, but it was brilliant, and it really
About
speaks
the code.
to...
Mm-hmm.
Yes, you know, but I think that, you know, in the past, you know, once you graduate, you have become an autonomous, independent position, and
Yes.
you do not get feedback. and you learn to not want it. And so once the culture's changed and the ABIM is now saying you need to get your feedback and your patients are putting on the web how they rate you, the culture is shifting a lot. But how many doctors actually give out a form to their patients, anonymously saying, tell me how I'm doing? It has to be mandated through, the survey center that our patients are going to evaluate us. So, our culture has been that we actually are not open to feedback at all.
Yeah, well, again,
I mean, we don't want people to now have generated reports of, what our patient outcomes are and how many, and how off we were in terms of the use of medications or screening for, flu shots or whatever.
I would argue that that's specialty specific. In surgery, we're giving feedback every Wednesday morning at 7 o'clock at M&M conference.
Mm-hmm.
And we're used to it.
Yes.
And we accept it. At least I hope we all accept it.
But does that happen in outside of an academic medical center? Is that happening in the Mount Kisco Hospital with the surgeons who are operating there? No. So it's the exception.
And also, what kind of feedback is that? I mean, that's M&M where people jump on each other, down each other's throats, criticizing what they should have done better.
No,
if my recollection is
that's your
accurate.
That's your perception. That's not reality.
Versus the kind of data that is reported through a patient survey. I think that's very different kind of feedback. That was the patient satisfied with what you did versus are your colleagues approving what happened in the I think it's different kind of feedback.
But that's okay. I mean,
but it's technical feedback.
You want multi-source feedback. You want there to be a lot of different.
Feedback in medical education is the feedback that, at least my perception as a third-year medical student in that room, is different than the feedback that is being reported online and by these kinds of.
And what we want for our learner may be different than the goals that want to be accomplished by M&M. That is, the M&M process was not designed for the second-year medical student to learn medicine. It helps with that, but that's not the goal of that session. It's quality improvement for the surgery department. So one size does not fit all, and one venue does not fit all. And I think we as a society, we need to be thinking about what are we doing, where are our sources of feedback, how can we improve them, who should be engaged in that improvement process. And what do we hope to accomplish? I mean, if it doesn't change behavior, it's all a waste of time. I mean, it's academic. We really want it to actually change behavior in a direction that we all agree on is an appropriate direction.
But that's why it has to be outcome-oriented.
Exactly. Right. What's the progress? What are we aiming toward? What are our milestones?
What isn't working, or what are the ramifications
if
you're acting this way? Or but then, the two issues. There's the technical skill feedback issue, which I think most people finally do accept and understand why that's important, because there's directly a bad patient outcome versus your interpersonal or communication skills, and that people take more personally, I think, than some technical procedure, and I think that's even harder to accept the feedback on that.
Well, and again, this is nuanced, but talking about being optimistic and being a good self-appraiser, we tend to be a little bit better at psychomotor skills, because there's more feedback about those. You know if you can play basketball or if you can't play basketball, but you might not know if you're communicating effectively with a patient or not, because that involves different kinds of skill sets that aren't always as easily quantified.
I also think that one needs to distinguish between ability to self-appraise and openness to feedback.
Correct. Those are not the same.
And in fact, I'm a psychiatrist. I spend my days with people who seem to be really, really hard on themselves. But I think it may also come down to the assessment tools, because I think the feedback that is the hardest to take is the one that most resonates with your concerns about yourself, whether or not you actually acknowledge it on a self-assessment scale.
Yes.
And people may be prone to overinflating whether they know it or not in a self-assessment scale, but when they go home and close the door and think about themselves,
that's a good point. Yeah, the research doesn't capture that. Real life captures that. But I think that's a very important distinction, whether or not we're appraising ourselves well and whether we're willing to hear the things that are very near and dear and close to our heart. What's the biggest problem that we have? It's usually not in the psychomotor technical skill. It's usually in professionalism or communication skills. And that's partly because of our ability to give feedback in that area, and partly because it's a hard thing to have people learn and teach. So, yeah.
And you're often faced with the negative outcomes of poor technical skills. Whereas you don't often get, your patient just doesn't show up again if they don't like your interpersonal skills. You don't know why, and no one's giving you that feedback.
It's harder.
You know, when they
It's
come
harder
back
to
with a
measure.
wound infection.
We fix the things that we can measure. I mean, that's, you know, and often the things that we can't, we ignore. And not because we don't want to do it, it's just because it's very hard, and it's hard for our learners to see. It's a complex business, and breaking it apart and figuring it out, I don't know. To me, this is just a challenging area, and I meant it. Thank you for the discussion, because I meant it to be I don't have the answers. I just have a lot of questions, and I know in my heart this is what we need to be talking about and discussing and trying to come up with strategies for, but I don't think we'll solve it easily, or will we ever solve it, because we're also working against things that are actually hardwired into our brains, and that doesn't change unless we have drugs or lots of counseling.
And also the stakes are quite high.
They are.
And I
They
think
are.
that's why it's even harder to hear that feedback.
I think we will eventually get to another plane, partly
Good.
biology. I mean, primates tend to live in groups, and that's what we are. We're not solitary animals.
Mm-hmm.
And so that is hardwired.
It's true.
That is how an effective primate group survives. And so I know in our schools we've moved to a team concept.
Mm-hmm.
The next element that I'm learning and hearing has to be, we've set up the structures, we're trying to understand. Some of us, at least me, don't have a full handle on how to most effectively do the feedback. But I think the fact that we're asking those questions, we've come a long way
That's a good
from over
point.
here to where we are here. And I think this rings a lot of bells. I mean, I don't know, honestly, how we deal in our introductions into medical school with feedback up front to what the expectations are on the part of our, and I know the entry years better than the clinical years, how much the students are going to have to know what should be our clear goals, what their role is going to be. I don't know how much we do that. And maybe because this is still pretty new, we're telling them about our teamwork, our efforts, our things, but the feedback is essential on that. And how are they going to have feedback to Dr. X and to Dr. Y and to somebody on a different level? I think we're going to get there as we're learning about the bits and pieces that we haven't maximized, but that we have to.
And I think the generations will push us a little bit, because they aren't as intimidated by the hierarchical structure. They also seek feedback much quicker and faster. We did a lot of teamwork in Minnesota, and we had our students, quote unquote, evaluate each other, you know, just give feedback. And we said you can do it anonymously, or you can tell each other who gave the feedback. And as a group, they wanted to know who. And they actually sought out talking to each other about the feedback that was given, which I thought was, you know, we were administrator, we're worried, we didn't want to pressure them, we didn't want to make them feel bad, but they said, heck, if somebody's going to tell me something, I want to talk to them myself. I want to know the names. So we gave everybody the names, and they proactively worked through it themselves, which I was gratified to hear. And again, I was nervous. I was nervous, but students weren't. No, let us have it. We want it. So you're right. Maybe the culture, maybe despite us, if we get out of the way of it, maybe it will change. I don't know. I don't have the answer. Pardon? Thank you. This is fun. Thank you for having me do this.